Good evening, everybody. My name is Gregg Gonsalves. I am an assistant professor at the Yale School of Public Health. Welcome this evening to our second town hall on the coronavirus pandemic. As you'll see, I'm standing in an empty studio at the Yale Broadcast Center, and all the panelists you'll meet tonight are at home in their own apartments and in their own houses in order to maintain social distancing, which you'll hear a lot about, spoken about tonight. I'm going to introduce our panelists. They're each going to speak for 5 minutes or so. Afterwards, we'll go to a series of questions. We asked you to send in questions until 4:30 p.m. today, and you sent in over 400 questions. So we tried to pull a representative sample in order to give you a wide breadth of answers to the things that you've all been thinking about. So without further ado, I'm just going to introduce our panelists, who you'll see on the screen here. I'm going to introduce them in order of their appearance. First is Ellen Foxman, who's an assistant professor of laboratory medicine and immunobiology at the Yale School of Medicine. She's going to talk about what is coronavirus, is it like the flu, what are its symptoms, its prognosis for different risk groups. Sten Vermund is the dean and the Anna M.R. Lauder Professor of Public Health at the Yale School of Public Health, and he's going to talk about the possible scenarios that could play out over the next few weeks and months. How bad might it get? What are the population level expectations for this pandemic? Next, we'll hear from Ann Kurth, who's the dean and the Linda Lorimer Professor at the Yale School of Nursing, and she's going to talk about what we can do to protect ourselves, our families, and our communities. Next, we'll hear from Rajita Sinha, who's the Foundation Fund's Professor of Psychiatry at Yale School of Medicine, and she's going to talk about how we can cope with the changes in our lives, the dramatic ones we're being asked to make right now. Next, we have Amy Kapczynski, Professor of Yale School of Law, and she will talk about what we can do to ensure our rights are being respected and the larger social justice issues that are raised by this pandemic. The last three speakers are going to talk about what's happening locally. Paul Genecin, who's the Chief Executive Officer of Yale Health, is going to talk about what is Yale doing, what is Yale Health doing. Mehul Dalal, who's the Community Services Director of the City of New Haven, is going to talk about what the City of New Haven that we all live in is doing right now. And finally, we have Sunil Parikh, who's an Associate Professor of Epidemiology at the Yale School of Public Health, who's going to talk about what Yale New Haven Hospital, our local hospital, is doing. So I'm going to ask Ellen to start us off, then we'll go to Sten, Anne, Rajita, Amy, Paul, Mehul, and Sunil, with 5 minutes of opening remarks. We'll go directly in order, one to the next, and then in about 45 minutes, we'll turn to questions. Ellen?
Thank you, Greg. Well, hello, everybody. It's nice to be with you virtually as we're all in our different locations. But I want to tell you a little bit about this new coronavirus and how it's similar and different to the viruses that you're familiar with. As you may know, viruses are tiny germs that when they get into your body, they make more copies of themselves. And in the process of doing that, create collateral damage, which gives you symptoms. So if that process is happening in your nose, you might get a stuffy nose, a runny nose. If that's happening in your throat, you might have a sore throat. And if that's happening in your lungs, you might have shortness of breath. Now, we have a lot of viruses we're all familiar with that do this every year, such as common cold virus, the flu virus, and we've all experienced these symptoms to different degrees. So the question is, what's different about this new coronavirus, why we should be taking all these extra precautions about it and be extra worried about it? And it comes down to this, the reason why this virus is so concerning is it's a new virus in the human population. So the other viruses we're familiar with, like common cold virus and flu, those come every year, which means that our bodies that have seen the virus before have built up some immune defenses against those viruses. And that means the viruses can't spread as well and don't cause as much illness as they otherwise would. The thing about the novel coronavirus is it wasn't in a human population before. It recently came into humans just a few months ago from another animal. And a few months ago, there's nobody in the human population who had built up immune defenses against this virus. So what that means is that the virus can spread more easily from person to person. and also has potential to cause more serious illness in a given person than it would have if it was a virus that many individuals had experienced before and had built up defenses against. So again, just like the common cold and the flu, it can infect the same parts of the body in the airway and in the lungs. But unlike those viruses, it has a lot more potential to spread from person to person and cause serious illness in certain populations. And just to answer the question, the other question that Greg posed, those populations appear to be people of older age. So people over the age of 70 have been hardest hit in getting severe symptoms by this virus. Younger people, especially people under the age of 20, can still get the virus and transmit the virus, but don't appear to have very serious symptoms. In general, another important factor is if you're somebody who has other long-term health conditions, such as breathing problems or diabetes, those kinds of things, it's important to be extra cautious with this virus.
That's Ellen Foxman talking about the pathogenesis of coronavirus infection. We're going to move to Sten Vermund, who's going to talk about the population level impact of the disease. Sten, are you there? I think Sten.
Thank you very much, Greg. The phenomenon of influenza every year is something that washes over the globe quite predictably and is a severe burden on the human race. We have a high degree of mutation, so there tends to be a new strain each year, and therefore we have to have new vaccine development each year. Every year, we're guessing what the new strain will be in the subsequent year. This is why we are very keen for people to be vaccinated against influenza every year to reduce the global burden of infection and also of disease and death. But the death rate for flu is about 1 in 1,000. And the death rate for the new coronavirus, which seems to be about as infectious as flu, as Professor Foxman just said, the new coronavirus, the death rate may be 1 in 100, so 10 times greater than influenza. Since this has been introduced to mankind or humankind recently, we would be very pleased to rid it from humankind the way that the 2004 original SARS coronavirus was eliminated. And we are not sure how to do that because this particular coronavirus is more infectious than that 2003, 2004 version of coronavirus was. But it's worth a try because we cannot afford to add another flu-like respiratory virus that recurs and plagues humankind year after year. It is worth a try to see if we can suppress it sufficiently to reduce the burden on our hospitals, to reduce the death rates in our vulnerable populations, mostly the elderly, and persons who have underlying medical conditions. And it's critical, really, that we do this with a sense of urgency, because if we fail to reduce viral transmission adequately when the new winter respiratory pathogen season comes about, we could see coronavirus added to influenza as a major global threat. So not only do we want to so-called flatten the curve to reduce the pace at which our hospitals are faced with this very serious condition, not only do we want to reduce mortality, but we also want to see if we can eliminate this virus in this transmission season. And if we can do that, it may be that the summertime is our friend with warmer and more moist air. We don't know if that will be enough to get rid of the virus because it's possible that herd immunity plays a role in why respiratory viruses are seasonal. And if we have very little herd immunity, perhaps that will work against us. But we're in uncharted territory. We've never confronted a pandemic threat of this nature, unless you go back to the Spanish influenza of 1918 and 1919. So at this point, we see a fairly rapid rise. The epidemic curve in the United States resembles China and Italy and Korea more than it resembles Hong Kong and Singapore, for example, where they were successful at containing viral spread. So we don't seem to have gotten a handle on this yet. For example, there were 1,000 new cases reported from New York City just in the past 24 hours. So we are seeing the uptick in the Connecticut curve, as well as the uptick in curves in many countries and states. And we're going to have to practice social distancing, shut down our economy for a while, see if we can control this virus for the long-term benefit.
Thanks, Sten. Our next speaker is Ann Kurth, who's the Dean of the Yale School of Nursing, as I said. She's going to talk about what we can do to protect ourselves, our families, and our communities. Ann?
Great. Thank you for joining. You're taking the time to educate yourself, to plug into a community of people who are also thinking and working on this current crisis. And so I applaud you for doing that. And I just want to acknowledge that this is, in fact, extremely stressful for everyone. We've emphasized the fact that this is a new pathogen. It's having an effect on our economies and on our emotions in a way that feels almost unprecedented. And so I think we can go ahead and acknowledge that and think about the things that we actually can do. So what are some of the things that we can control? And there are some common sense guidances that are things that you can do for yourself to reduce risk and for your family, and that will help in your community as well. I'd say for some of these things is just to try to keep yourself in as good mental and physical shape as possible. One way to perhaps do that is to try to shut down some of the constant noise and the barrage of news. So find one trustable source like the Centers for Disease Control that you can listen to maybe once or twice a day, not every hour, not every 15 minutes, just to control and stay up to date with trustable news and information and science. You've heard about social distancing. We're all trying to practice that now. I like to say we're all standing together 6 feet apart because that is really the perimeter in which this pathogen, which is spread by droplets when someone sneezes or coughs, falls. So you want to keep that perimeter. We also want to ensure that we are not gathering in groups, and there have been many guidances around this, as you see, businesses, places of the arts, even hospitals restricting the number of people who can come in. All of this is towards that common goal that we're working for to reduce the transmission of this coronavirus from one person to another. Hand washing, everyone should know it by heart. You're singing happy birthday twice in your head as you wash with soap and water for 20 seconds, multiple times a day. This is going to be good for the health of everyone, including our small children. So make sure that they are also getting their hands washed and managing our sneezes and coughs, again, to reduce the respiratory droplet transmission. Speaking with your children or young people in that you're taking care of, you'll just want to give information that's factual, that acknowledges their concerns, and that's age appropriate. And again, keep your own trusted sources of communication going. Getting ready for taking care of yourself and others at home is something to think about. So we should all be sort of monitoring ourselves, and if we start to have a fever, dry cough, and fatigue, ideally we would not bring that to a workplace or to a group setting where we might encounter other people if in fact we are infected. We are concerned about some of our folks more than others who are at higher risk of more severe morbidity and mortality with COVID-19. This includes people over age 70 and people who are immunocompromised, have heart and other conditions who would be more at risk. So we want to take care of particularly our more vulnerable members of the population. We want to ensure that if we are working in the workplace, as I said, that we hopefully are getting the message that we can work from home, or that we will continue to have the opportunity for our pay and our entitlements to keep coming. And the U.S. government has been looking at injecting money into the economy in order to do that, so that we don't, in the midst of sort of having our economy shut down and having to be more homebound, really run into trouble for keeping our own families going economically. So we do also need to know our rights and advocate for those good policies. Care at home, again, schools and daycares are often shutting down, so just being able to cover childcare. We are looking into, for example, here, ways to try to get childcare coverage for our health workers, who we do need to go into the health system to take care of patients, both COVID patients and non-COVID patients. So if we become sick or exposed with a fever, stay home. If you do get COVID-19, because many of us will actually become infected and have a relatively mild case of COVID-19, please stay home until you've recovered, and just take care of your mental health and of each other. Thank you.
Thanks, Anne. Our next speaker is Rajita Sinha, and she's going to talk about how we can cope with the changes we're being asked to make in our lives, which are pretty extraordinary, even for many events that we've experienced over the course of our lifetimes.
Thank you, Greg. It's a pleasure to be with you all, even though these are difficult circumstances, and to get a chance to talk about this. Indeed, we have been asked to make some rapid changes in our lives in a short period of time, and you've already begun to hear about some of them. The first one you just heard about was social distancing. Really a number of recommendations like that to reduce the risk and to prevent getting exposed. The psychological side of social distancing and pulling back from your net community and your social network can be difficult, particularly in the context of having to and not actually connect socially, physically with loved ones. And so one of the things that we want to remind people to do is to still stay connected using FaceTime, using other technology and social media, and really stay connected with your family, with your friends to get social support, because social support is a really important aspect of buffering under stressful conditions. The second thing that you heard about already is that workplaces are changing and asking people to stay home or not come in, and there are lots of challenging and difficult fallout from that, either losing pay, which you've heard about, but also suddenly finding yourself being in isolation if the workplace is a place where you are in fact connecting with others. So feeling a sense of disconnectedness. On the one hand, it can be rejuvenating in terms of time, and you could get more work done. On the other hand, it can be disconnecting. And so it's really important to really develop a schedule, to list the kinds of things you can do, and again, connect with others. The final thing that I want to talk about, which I think is the big one, which is when you don't know who is going to get it, whether you're going to get it, whether your family is going to get affected, when it will be here, that really increases our fear and anxiety and a sense of panic. And so those emotions are difficult to cope with. They increase stress levels. And it's important to acknowledge that, to start by really accepting that this is a difficult time. And there's a lot of things that we don't know. And so it's important to pay attention to the recommendations, but also not overwhelm ourselves with news and information. Sometimes you might get involved in a lot of conflicting pieces of information, and that can create confusion about what to listen to. And so, as you already heard, you want to focus on the things, reliable sources of news. So in the spirit of that, let me just give you a couple of points of and resources. So the Centers for Disease Control actually has how to manage life and the changes during this period, and has a section on managing stress and anxiety. So I urge you to go there. The American Psychological Association has lots of resources posted on their website. The Yale Stress Center here right at Yale will be offering a free class starting next Wednesday for 30 minutes every week for the next number of weeks, and that's on the yalestresscenter.org website. And so there are a number of resources that can provide you with information on how to cope, as well as tools, skills, and strategies on the best ways that you can cope that would match your particular skills and abilities. Thank you.
Thank you. Next is Amy Kapczynski, who's going to talk about the sort of the human rights aspect and the social justice aspect of this pandemic and what's facing us. Amy?
Thanks. It's nice to be here with all of you. And so Greg and I have been working together, actually, with many others on the broader rights and justice implications of the pandemic. I wanted to say a couple of things. First, there's a number of places where we've tried to specify how to protect rights in the context of COVID. And really what that means is that our government has to step up and provide protections for people and really create a surge of social support. And so some of this is detailed in an expert letter that Greg and many others and I contributed to. I'm going to provide links to that and a few other things alongside this video so that people can access some more details on some of this. But just to say a couple of things about what's important to think about. So we really have been concerned for a long time now that not enough is being done to protect our rights and to protect people, that we need a major sort of infusion of public support. Now that's under discussion now. We really are starting to see some action in that regard, both nationally and locally. We need, obviously, to think about how to increase our capacities with respect to hospitals, how to protect healthcare workers, and how to protect everybody who's going to seek healthcare, for example, by ensuring that nobody fears immigration enforcement if they're seeking healthcare, or fears that contact with public health officials put them at risk. So we also need to be able to have science-based responses. So there's a lot of course, action going on, and things are changing very, very quickly with respect to what the states are doing, with localities are doing, and more slowly the federal government is doing to try to respond. So broadly speaking, the state has pretty broad public health powers to require things like quarantine or other social distancing measures. So people are probably wondering, what can the state do? How far can it go? What are our rights in that regard? So let me say a little bit about that. So every state has its own laws about powers like quarantine, for example, but many of them have broad statutes that allow them to take measures that are necessary for health and safety. Many states are asking for cooperation, and that's a good thing. Where they can do things voluntarily and not issue orders, that's a good practice. But there are also places now, we see what's happening in San Francisco with respect to the shelter-in-place order, and many other states with respect to, for example, bars, restaurants, and schools are ordering closures, and the state does have broad powers to do that. So if it is the case, though, that social distancing measures restrict rights, then they have to be especially well justified. So both the state and federal constitutions protect our rights in various ways. One thing to know generally about US law, though, is that the kinds of rights that we protect are limited. So we protect liberty very strongly, for example, but we don't have a right to food or healthcare in our state or federal constitution. So if the state does do things that restrict liberty, for example, ordering somebody into quarantine, there are protections that do exist. The law is, there have not been that many cases about these kinds of things. So it's sort of challenging to set out what the legal requirements are. But just as a general, very broad standard, if the state's restricting liberty, one of the things, our view of their legal requirements is that the quarantine, if it's a quarantine, for example, it has to be necessary, justified by science, and the least intrusive means of achieving the end. Even if a measure is justified, the state does also need to follow certain rules when enacting it. For example, you have to provide clear justifications. People need notice of what's expected of them. they need information about how to challenge any restrictions. So you can be allowed some kind of independent review. If you're being, for example, ordered to stay home, then the state has to give you adequate care and food. So it's important to know that those kinds of legal supports have to be taken care of if the state does do things that restrict your liberty. So broadly speaking, another emphasis that we have been all trying to pay attention to and call for is more social support to allow people to follow public health advice. So broadly speaking, there are all kinds of things that we need to do to be able to get people in a position to do the social distancing that, of course, we all need to do right now. And some of that has to do with providing resources directly to affected people and to providing resources to those who are hard hit in the community. So a couple of things about that, and I'll just speak more specifically here about Connecticut, because I know there'll be a lot of local people who are interested in how to think about the benefits that are available to them. So I'm mostly going to summarize here from some excellent information that was provided to me by Alice Rosenthal, who works for the Center for Children's Advocacy, Medical Legal Partnership, and Shelley Jabal, who is Assistant Professor of Clinical Public Health at Yale. So many other states will be doing similar things, but this is specific to Connecticut now. So unemployment, for example, may be available for some people, and Connecticut has relaxed the rules for who is eligible. So right now, the state is encouraging everyone who is currently out of work due to the pandemic to file for unemployment ASAP. Any worker who receives health insurance through their employer and becomes unemployed and loses minimum essential coverage, or whose Cobra expires, whether because of COVID-19 or otherwise, is going to qualify all year long for open enrollment through Access Health CT, which is the state's health insurance marketplace. There's actually a new special enrollment period that was just announced so that people who are uninsured can now, from March 19th to April 2nd, if you are uninsured, you can enroll now, again, through Access CT, Health CT, for health insurance. So there's also financial help available for those who are in need. With respect to housing, of course, many people face housing issues, and housing is going to be critical to being able to engage in social distancing and protect people's health. Here, there's still a lot of advocacy going on. So far, what we know is that there's been a suspension of hearings and defaults and executions in Connecticut's housing court until April 1st, 2020. So that means that those facing evictions may have some relief. There's also been steps taken to order utility providers to suspend shutoffs for the duration of the public health emergency, regardless of people's ability to pay. Schools are providing meals for children who attend their schools. For further details on all of these issues, as well as how people can apply for things like cash assistance and food stamps, follow the links that I'll provide associated with this video. The last thing I just wanted to say here is that all of this is going to be evolving very quickly. Many of these things may be out of date in just a few days. The last thing I'd urge you to do is to contact your local, state, and federal representatives to tell them what you need to make yourself heard about the hardships to your families, to your businesses, to your loved ones. And many of our state legislators are also providing useful updates on this daily changes that are now happening to try to provide support in this context.
Thanks, Amy. Next, we're going to have Paul Genecin from Yale Health to talk about what the health plan is doing for staff, faculty, and students at Yale. Paul?
Thank you, Greg. Hello to everyone. I'm Paul Genecin. I'm director of Yale Health. Several weeks ago, Yale President Peter Salovey appointed the COVID-19 or Coronavirus Advisory Committee. This 12-member group has quickly become a multidisciplinary task force, meeting daily by Zoom. We have Yale public health experts, representatives from Yale New Haven Hospital, as well as Yale Health, and leadership from our schools of public health, nursing, and medicine. In fact, two of our members are Deans Ann Kurth and Sten, Vermund. We found many opportunities to work together to track the coronavirus epidemic and improve our response as a university, as healthcare providers, and as members of the greater New Haven community. We've recommended public health actions to our university leadership to reduce the risk of contagion, and examples include defining criteria for isolating and monitoring individuals in whom the diagnosis of COVID infection is suspected or confirmed, and developing ways to care for them at home while protecting the community while these patients are contagious. We've developed ways to register, to isolate, and monitor returning travelers from high-risk areas. Examples are China, South Korea, Iran, and now all of Europe. We've made recommendations to reduce gatherings to minimize the spread of infection and transitioned to Zoom and other technology for teaching and meetings and gatherings. We've also recommended reducing activity across the university to protect our workforce, our students, and our community. We're working to ensure clear and reliable communications with our community. For example, with email messages and online content that we update frequently, providing answers to frequently asked questions, also advice for people on how to stay healthy. We have instructions for people with symptoms and concerns, guidance and resource for travelers, and links to reliable online resources. Our group is fostering communication and collaboration between Yale University, Yale and New Haven Hospital, our state and local health departments, and government leaders. And we've worked to adapt and expand patient care capacity to respond effectively to the COVID pandemic. One example is opening telephone access through a hotline and call centers to deal with many COVID-related concerns. We've initiated telephone screening, instructing patients to call first before entering healthcare care facilities. And this allows us to avoid transmitting respiratory infection, but still allowing us to see patients who may have COVID safely. We avoid accidental spread of this disease to other patients and to staff. We've also worked on ways to scale back non-essential care encounters and to transition to telephone, telemedicine, and in some cases postponing care that can safely wait. And this is maximizing our access to patients with concerns about COVID, and it's also making sure that we have time to take care of patients with other non-COVID related immediate health concerns. Our group has focused on increasing the workforce of physicians, of nurses, and other essential healthcare personnel to take care of people, whether they're at home or in outpatient settings such as offices or also in the hospital, of course. Now, you may know that our country has been slow to roll out testing for coronavirus. So our work group has put a lot of work into diagnostic testing capacity and testing criteria for patients who are hospitalized with acute illness, as well as others. We're also concentrating on ways to protect healthcare providers and their patients from the spread of COVID infection in healthcare settings. This, of course, includes face masks and other environmental and personal protective equipment, but also ways to deal effectively with healthcare providers who may have been exposed to infection to make sure that they do not spread the infection to others. And then last but not least, we are collaborating with the health department and with our colleagues at the Yale School of Public Health on the important task of contact tracing to identify and counsel those exposed to known coronavirus patients. We give these people that we identify information to keep themselves and their communities safe, and we advise them on how and when to seek medical care if they need it. I look forward to your questions, and I hope that everyone stays safe and well. Greg?
Thanks, Paul. Next, we're going to hear from Dr. Dalal at the City of New Haven about what the city is doing. Dr. Dalal?
Thank you, Greg. I want to start by saying a word of gratitude to all the staff at the city who have been putting in immense amount of hours in relation to the response to this epidemic. It's a privilege to work under our mayor, Mayor Justin Elliker, alongside with our Director of Health in New Haven, Director Maritza Bond. This has been a time of unprecedented activity and response to this crisis. And I'd like to say from the city perspective, I break it out into kind of 3 phases. The first phase when we saw the tsunami coming from far away. And our main concern at that point was putting out clear communication about infection precautions. We ramped up a number of messaging campaigns focused around flu. At the time, the flu was a main concern with respect to public health. We knew the messaging around flu would apply to coronavirus when it hit Connecticut. However, the general public was not as in tune with the threat of coronavirus as the public health official and the public health community was at the time. So we thought that focusing our message on flu in the early phase of the pandemic was the way to go. The second phase hit us pretty hard. The second phase, I think, I mark by the event at Yale that needed to be canceled because of a suspicious case of coronavirus in a visiting student that turned out not to be a positive case, but it heightened the community's awareness and the fact that this virus was going to hit eventually our community. In that ramp-up phase, we escalated the frequency of our meetings, both internally with city staff and externally with our partners, continue to ramp up the education and messaging around preventive precautions that one could take every day that were discussed previously on this video. Then we also started in the background planning what we would do for city operations when this the coronavirus would appear in Connecticut. Of course, the third phase right now is the one that I would describe ourselves in right now. This is a period of, and it's marked by the fact that we do have coronavirus in Connecticut, escalating exponentially just over the last few days. This is a period of intense operational work. There's a multi-pronged strategy being coordinated through the city in coordination with the state, in coordination with the Yale New Haven Hospital, in coordination with Yale Health, which includes not just a traditional public health response, but also a standing up a community health and well-being strategy, standing up a intense public communication strategy as well. We had our own site go live that's dedicated to COVID for New Haven just in the last 24 hours that focuses on local level information that our community needs to know about with respect to COVID-19. Our operations, there are many aspects to it, but I would say there's 3 major buckets to it. The first is a community well-being strategy, which focuses on outreach and protection of our older adults, including intense outreach and technical support to facilities that house older adults, such as nursing homes, but also multi-unit dwellings where a lot of adults live potentially in subsidized housing or in NORCs, naturally occurring retirement communities. We are standing up a community-wide food distribution strategy. The New Haven Public Schools has led the way with respect to making sure that the kids who are no longer in school are receiving meals or have the opportunity to receiving meals. We understand that when we talk about older adults and even more or less the entire population, advising them to stay home and not gather, not everybody's going to have the opportunity to eat. They rely on food pantries or other food distribution services. So we're working on standing up a community-wide food distribution strategy. We have a specific strategy that's targeted towards homeless individuals. They are in a very unique and difficult circumstance that if they are told that they have COVID-19 or they are suspected to have COVID-19 but do not meet acuity level for hospitalization, they do not have a place to self-isolate. So we are looking to stand up a quarantine facility for that purpose. And finally, we have an emerging mental health and well-being strategy headed up by a partner organization that will be looking at the mental health well-being aspects of our unprecedented situation where we are asking individuals to stay at home, whether through recommendation by a medical professional or a public health professional, whether through public health order, or whether just a general recommendation to not gather in groups. The second bucket is our public health response. This is the piece of the bread and butter, what public health trained for with respect to identifying positive cases, doing the contact tracing those positive cases, advising and counseling those who may not be exposed, assessing the exposure risk, and counseling accordingly. In this bucket includes our ongoing daily, or if more than daily, I would say ongoing everyday communication with our health systems partners. That includes Yale Health and Yale New Haven Hospital. That collaboration has been very much appreciated, and we need to have this ongoing collaboration in order to respond effectively. And finally, if you are local and you're watching, you are in the New Haven community, you know that over the last week, we have put forth an escalating set of policies that complement the state escalation with respecting to promoting social distancing, not just through messaging, but through actual policies. Some of that includes the school closures, the recommendation to close, actually the requirement to close larger daycare systems, and other orders that will be forthcoming. And finally, we have the third bucket is a public communication strategy, where we have daily press briefings to provide the public updates on the most recent information and education and around COVID-19 and its cascading impacts in our community. And it also includes a component to special populations and segmented populations regarding what they need to know. This includes faith leaders, non-English speakers, communicating that stigmatization around this disease is not acceptable, and particular outreach to our businesses and our small business community to understand their impacts. Thank you.
Thank you. And finally, we have Sunil, who's going to talk about what's going on at our hospital, the Yale New Haven Hospital here in New Haven. Sunil? You're on mute, Sunil.
Hi, can you hear me?
Yep.
Excellent. So I will be probably repeating a bit of what Dr. Genecin and Dr. Dalal had said in their statements. I'm an infectious disease physician, but an epidemiologist at the School of Public Health, but also see patients at Yale New Haven Hospital. And first of all, I just want to really give credit to the amazing leadership, the nurses, the physicians, and the staff at Yale New Haven Hospital. This has been an extremely rapidly evolving situation, a lot of pieces of the puzzle, and I've just been really amazed by the work and dedication and passion that everyone's putting into this, and really the empathy that everyone has for everyone around them. So I'm really speaking on behalf of many other people. I also want to really reassure the public that folks are really at the hospital system are doing everything that they can to really curb this epidemic and take the best care of those affected. I know there's a lot of worry out there, and appropriately so, with not having tried and true treatments available for this disease, but folks are really doing their best for supportive care. And again, it's a very rapidly evolving situation. Just to kind of highlight that, we had, really our first positive case. We began this weekend really with our first positive case at Yale New Haven Hospital. And at this point, we have, I believe, about 8 inpatients now at the hospital. So again, things changing very rapidly. I want to, again, let folks know that those entering the hospital system, they are really making a lot of changes on a daily basis. Yale has really established, or in the process of establishing, a floor that all patients with COVID will be sent to, and that really has the effect that we see in the community, as well as social distancing, so that within the hospital system itself, we can really limit exposure of other patients who are there for other reasons. And I think that's something that I think can provide some comfort to those outside the system, that knowing that at least patients with COVID will be really not spread throughout the hospital system. Other measures I think that Dr. Genecin also mentioned is that visitation to patients has been limited and restricted with certain floors having a little bit more of a liberal policy, such as pediatrics, where interaction with patients are necessary, of course. Again, that is really focused on us being able to limit the spread of the disease. They're making adjustments to the SMILO, the cancer hospital, surgical floors in terms of outpatient elective surgeries and whether those should be pursued, and really all different aspects of medical and surgical care are being readdressed on a literally hour by hour basis. I'm sure many are worried about the workforce situation, as we are. For many of these epidemics, the healthcare workers are the ones that end up getting affected early on and over the course of the disease. But a workforce plan has really been developed to mitigate the risk of staff shortages through this epidemic. I think Dr. Genecin also mentioned the telehealth visits, and I think that's going to be another powerful way to really limit patient exposure into the hospitals. In terms of those, I don't want to spend too much time on just the clinical aspects of things, because I think this has been covered in the news and in other sources and maybe raised in questions. But I think just to reiterate that the primary point of contact should be your physician, and that is the person that can really help direct where you should go for whether or not you should go for testing and how to proceed from that point on. But we're really urging folks not to enter the medical system without first contacting their primary physicians, again, to limit exposure. One of the most, I think, helpful things was the establishment of a call center, and that was really established very early on in this process. It's being staffed by, among other individuals, Yale infectious disease physicians, trained physicians. Early on, with the limited availability of testing, they had a very important role in determining or helping to determine who should be tested. But now I'm happy to say that Yale New Haven, the lab has been fantastic, and they are now able to run testing for inpatients within the Yale New Haven system. For folks getting tested in the outpatient ambulatory system, those are being sent to a different location. But we now have a significantly increased capacity for testing throughout the system. It's not yet where we'd like it to be, but it's significantly better than it was early on in this pandemic. I'd also like to let people know that we are kind of sharing information between one another on the clinical services. I think almost every department is having, if not daily, multiple times per week, having department-wide calls to share what we're learning on an hourly basis, daily basis, so that we can provide good care for those around, those presenting. And I learned today that this is not just occurring even within departments. There are folks reaching out to physicians in China and Europe to learn the most we can from other experiences and other places that have had the epidemic hit earlier than we have. So I think we're learning things in a real global way through this epidemic. And I'd say kind of the last thing I think has been on the mind of individuals certainly is the treatment issue. And while there is no proven treatment yet for COVID, the Yale system has put together both, there's individuals as well as groups that have been put together to try to look into investigational therapies and see if Yale can become part of clinical trials that are going to be unfolding in the coming weeks. So I hope that answers some folks' questions. Thank you.
Thanks, everybody. It was miraculously on time. We should do this online more often. So we opened up an email box for questions at around 9:30 a.m. This morning, and by 4:30 p.m. there were close to 400 questions from all around the world. I don't think we have time to go through all 400 questions, so I pulled out a representative sampling of them that we're going to try to go through between now and the next 45 minutes that we have left. read the question, then I'm going to turn to our panel. And if you would like to answer the question, raise your hand. If there are two of you, we'll go in turn. The first question is from Moira Van Grove from the UK. It's one of our more distant questions. She said, and this is representative of several questions that came in from locally in New Haven all the way across the country. I'm a very healthy 73-year-old. Why am I being told to self-isolate? Who would like to take this question? Ellen, you have to unmute yourself. You're muted. Go ahead.
Okay. So that is a great question. I think what it is this is a new virus in the human population, and we're just learning about it. We don't know all the details, but one thing we do know is how different age groups have done with this virus. And what's one very interesting thing is young people, especially children, even though they get the virus, do not appear to get very sick in general. And we also know that the highest risk age group is elderly people and people with other health problems. So if you're in the age category over the age of 70, you're at significantly higher risk of having a serious disease. Now, as we learn more about this virus, maybe we could break that down into, a healthy 73-year-old versus a 73-year-old with this health condition, but we don't know that yet. All we know is that people over the age of 70 are in a very high risk category. So it's a very good idea to try to not get the virus. And the most tried and true way of doing this, even though it seems rather dull, is to just avoid exposure.
Thanks, Ellen. The next question we have
Could I add to that just briefly?
Go ahead, Sten.
Mortality rates in early data from Wuhan, China were less than a fraction of 1% in young people, but 15% in persons over 70. Similar data from Korea were not as alarming, but still death rates were over 6% in Koreans. And we're seeing some data in Italy that also suggests what Professor Foxman was highlighting. So yes, some of those people have underlying medical conditions, but as someone who's over the age of 65 myself, I can tell you that the evidence is that we do lose immune vigor just as a natural part of senescence, as a natural part of aging. That's why we recommend things like pneumococcal vaccine in people over 65 and other vaccines that are like the shingles vaccine that are going to afflict you more often if you're a little older, and just age can be associated with a less robust immune system.
Thanks.
I think
Sunil.
just a second here is piggybacking on that. I think we have examples even from the United States with the unfortunate situation in Seattle with the nursing home. So, largely elderly population, and that had a mortality much higher than we had seen really in any other situation.
Thanks. I'm going to go into the next question from Chris George, who is a New Havener and who happens to be the executive director of IRIS, the Integrated Refugee and Immigrant Services organization here. And he has a question. I'm just going to read it. Thank you for your heroic efforts to deal with the COVID-19 outbreak. Having worked in partnership with Yale New Haven Hospital for more than 15 years to serve the needs of immigrant communities, particularly refugees, IRIS is grateful for your commitment and high-quality services. Although we don't have anybody from Yale New Haven Hospital here, it says there's some confusion about provision of free services for COVID-19 related issues to uninsured patients. I am sure I don't need to remind you how important this is to remove barriers to healthcare at this time. What's the best way to get clarity on this issue? Does anyone here have a sense about the status of the uninsured and seeking care in the city? Does anyone know?
Well, I think it's fair to say that if Yale New Haven Hospital is contacted with a potential coronavirus case, that case will be triaged like anyone else, regardless of insurance status. And that would go for a trauma victim or anybody else. So I acknowledge that getting a bill from a hospital at the end of a day is immensely burdensome, and people without health insurance, one of the fatal flaws of our American health system, that we have so many people without insurance. But nobody's going to be turned away for care because of lack of insurance.
I do also want to add that I believe that now the state has assured us that DSS will cover the cost of testing for people on Medicaid and Husky, and also for those who are undocumented. Now that's just testing. But as Sten said, it's important for people to know that they can get care. And, we are seeing a lot of, a lot that's on the table now at the federal level. If the federal government provides more support, the states will be able to provide more support. But I do hope we can also get somebody from the hospital to speak directly to sort of what their policies are with respect to these communities.
I think I saw Dr. Dalal's hand up.
Yeah, I just wanted to notify for the New Haven community, both our community health centers are online with testing as well. So if there's trouble accessing the testing at Yale New Haven Hospital and they happen to be can access the community health centers, they are also doing testing.
Okay. So the next question is from Molly Connolly, who's asking, what daily changes should pregnant people be making? This came up, the question of the risk to pregnant women, it was 5% or more of the questions that came in over the past days. So can anybody offer some guidance here? Sten?
The evidence from China and Korea is they have not seen untoward events in pregnant women. It does not seem to be more severe in pregnant women, nor is it less severe. So clearly, being younger is an advantage for pregnant women compared to being over the age of 70, for example. Now, we do not have good data on someone who is infected in the first trimester of pregnancy, those first 3 months after conception. So that remains an open question. However, pregnancy management has been the same for infected individuals. I can tell you as a pediatrician, we don't want pregnant women getting infected with anything. So cautious approaches to pregnancy and exposure are in order, as they are for all of us, but pregnant women should be especially careful with social distancing.
Anybody else want to respond to that?
I would say, in addition to that, the only other information we have, there's not great information on what to do with breastfeeding, and I know that's come up with individuals, but I'd say, again, probably contacting your obstetrician in that situation, or pediatrician. At the moment, there's been no evidence or no data to suggest that it can be transmitted by breastfeeding. However, there's really limited data on that. So we are encouraging people to reach out to their obstetricians and pediatricians if they are breastfeeding and they have come down with symptoms of COVID, and to get further guidance at that point.
This is Ann just jumping in, and to also work with their midwives if that's who they're delivering with. We do want women to have support throughout pregnancy as well as their birth plan and postpartum, knowing that with the current hospital restrictions around the number of people who can be in the room, there may be some alterations in that. But again, to protect oneself as much as possible to stay healthy during the pregnancy outside of COVID.
So move on to the next question, which is about the effects of isolation on very young children and their caregivers by Farron Tang. She asks, what might we expect to see in terms of potential effects on the socio-emotional development of very young children, toddlers, preschoolers, of complete physical isolation from other children for a potentially prolonged period of time? Does anybody have any thoughts on that? Dr. Sinha, perhaps?
So I can say that it's actually not good to have children be isolated, but very young children are with their parents, in terms of being at risk. If you're isolating, you have to take the precaution of social distancing, but that, again, does not prevent you from engaging with the children, talking with them, communicating with them, really expressing a lot of emotion in other ways. And that's very important at these times. So I would say that to keep up the communication, both nonverbal and verbal communication, and warmth and love and belonging is real critical at these times.
Thank you. Anybody else?
We're looking for closed units. Network theory suggests that the greater the outreach that you have, the more risk you have of getting infected. So if there were next door neighbors who were staying at home, not going out, those two children played, and those families interacted, preferably with the 6-foot social distance, that would be highly preferable than compared to, say, a babysitter who's going from house to house with different calls. So the notion of a highly restricted network is a very superior idea than a larger daycare with many children from many families. So when we're talking about children and their inevitability of running next door to their friend, what we'd like to do is have those networks be very small and very contained. And that will be a much better situation than, say, an alternative to closed schools where parents who have to go to work put their children in some days, not other days, other children come in. That sort of thing is much, much more risky. So one has to perhaps limit the child's friendship group to a very, very limited pool if that's absolutely necessary.
Okay, thank you, Sten. The next question is fairly specific, and I know who's probably going to answer it. It's from Kate Nyhan, who's our research and education librarian for public health here at Yale University. And she asked, it would be great to hear about what legal strategies are available to avoid or mitigate delays in vaccine development or manufacturing with respect to patents and licensing. I think that might be for Amy.
I've worked a lot on these questions about patents and so forth and how they can interfere with both access to medicines at the end of the day and also with the development of medicines. So one thing to know is that patents are granted by the government, and what they do is they prevent anybody who holds a patent from, so anybody who holds a patent is allowed to prevent others from using that invention. And so they can get in the way of both the kind of free exchange of scientific information and of people being able to access broadly something like a new vaccine. There's going to be a lot going on. There is already a lot going on in the vaccine development space and in the development of therapeutics. We've all been hearing the same account, and it's what I believe to be the case, that we're talking at least a year for any kind of vaccine. Perhaps therapeutics could happen faster. But one of the things that it's useful to know is that the government does have the authority, if patents are getting in the way with respect to the access at the end of the day when something's developed, or with respect to developing a new technology, a vaccine or a treatment. They have the ability to say that people have to collaborate and that we can override patents and provide royalties effectively. And so that's not a right that the U.S. government has used very much. But one example, which seems pretty salient now, is many of you may remember back to 9/11 when there was a concern about anthrax. And because anthrax, to be treated, you needed a drug called Cipro, which is owned by a company called Bayer. They were the ones that held the patent. They couldn't supply sufficient amount to the federal government, and the prices were very high. This is obviously sort of opportune moment for price gouging. And the federal government threatened to use this power, which I've written a lot about, called the government patent use power, to say we're going to override your patent and we're just going to buy generic drugs from somewhere else. And the company immediately lowered the price in half and made much more available to the government. So the government does have these powers, and it'll be important for our policymakers to be thinking ahead. If we're going to be funding, as we are now, a lot of the development efforts, to be ensuring that those come along with guarantees that there'll be access at the end of the day, that taxpayers aren't paying twice, both to fund the treatment and to then afterwards paying exorbitant prices for it. It'll also important to be paying attention to once we do get these kinds of things developed, to access through these tools like government patent use.
Thanks, Amy. I'm going to move on to our next question. Is from Jason Manto, who is a student at the Yale School of Nursing. Jason asks, what services and efforts exist right now for the elderly, the poor, and the recently unemployed as a result of the stay-at-home measures? Have we assessed the needs of these populations, and can we meet that need, and what services exist to meet those needs in the city of New Haven? Dr. Dalal, you want to take that?
Yeah, I'm just unmuting here. Yeah, I'm happy to take that question. So it's important to remember this this type of this has come so fast that providing the services requires an entire retooling of our current social services network. This is happening pretty rapidly, but it takes some times in terms of ensuring the logistics will work. And not only the logistics work, but the logistics are now under the auspices of a public health framework. So I'll just start with one example. Food distribution would typically, as long as it passed a standard set of public health requirements of sanitary precautions, we would sign off on that as an appropriate food distribution program or food delivery program. In this scenario, we have to consider the social distancing aspects of food delivery, which means that if we were to distribute food from a certain location, are there the logistic and aspects in that planned out to the fact that many people don't rush to that single site in order to pick up their meals? We also have to think about the precautions that the food delivery personnel or food distribution need to take, and educating them about distance. So there is a ramp up period with respect to the availability of these services. I mentioned earlier in my remarks, we have a strategy to outreach to every single facility that may be housing elderly, either in a nursing home or a congregate setting. My hope is that we would be, by congregate setting, I mean multi-unit housing places. And my hope is that we would be able to muster volunteers to make a contact with every single senior in New Haven to understand what kind of supports they need, and if we're assessing their supports, to be able to deliver on those supports.
Thank you.
Greg, I can add that just to remind folks that there's the Connecticut Mental Health Center. Coping with this risk and the worry about it can be very anxiety provoking. And the Connecticut Mental Health Center is state supported and available for mental health needs, but also providing information, helping people cope, and also to get to the right services. So that would be an additional resource.
Thank you. Next question is also from a nursing student, Kelsey Jug. She's saying, I'm a first-year student at YSN. I'm a babysitter and also have volunteered for surge capacity in the hospital. I've had people tell me I shouldn't be babysitting if I'm going to be stepping foot on the floor at the hospital at this time. Should healthcare workers in hospitals give up all social interactions, even small groups with social distancing? Or should we simply continue our other responsibilities with the necessary precautions of distancing and hand washing, et cetera? This is in the context of a bunch of other questions about, is there a role for volunteering for people who want to do services for the elderly or people who can otherwise go out? This is a very specific one around healthcare, but you could take this as a more general question or a more specific one about people in the healthcare industry or in the healthcare fields. Who would like to answer that? Anne?
So our healthcare workers are a really precious resource, and people talk a lot right now when we're thinking about the potential implications of more patients in the hospital with acute healthcare needs about ICU beds and ventilators. Let's not forget the staff who actually have to be there 24/7 with patients. And so we are really thinking quite carefully about all of our workforce needs. Nurses tend to be, as with all other pandemics, on the front lines, spending the most time, certainly in hospital settings, with patients. So many schools of nursing in Connecticut and around the country are really trying to ensure that we can continue the education of our students safely and fairly, while also thinking ahead to some workforce needs, including the opportunity for students who are licensed, who are RNs, for example, not pre-licensure, to be able to engage in some what will be likely to be some surge activities. The thinking there is that there may be different levels of care, no patient contact, as with phone banks and phone triaging, for example, lower level patient care activities, and then higher level acute care activities that may involve aerosolizing procedures. For all of the care in the hospitals and health systems, it must just be said, one of the other failings as we dissect the lessons from this epidemic is going to be around personal protective equipment and the constraints in the supply of that equipment, PPE, that we're calling. There really is, that's really extremely problematic. So we do want to protect our health workforce as they are engaged in care in the hospital or in volunteer activities in the community. And so following standard procedures around trying to social distance and stay home if ill, get treated and recuperate at home with a mild case of COVID so that you can even go back into the health workforce, because we will be needed, health workforce will be needed for some time.
So I just want to pivot to a question which related from Julian Morton, who's from the Yale College class of 2020. He says, for those who are able-bodied, relatively young and healthy, what can we do to help more vulnerable individuals in New Haven without putting ourselves or the larger community at unnecessary risk? So it's another volunteering question. Ellen? Unmute.
Oh, yes. So, I mean, one thing that young people that age can do is take the precautions that we're recommending. It's hard, especially at that age group sometimes, to have the more social distancing and to take heed of that, especially you hear sometimes young people talking about the fact that they don't feel as vulnerable to it. But I think that sort of realizing that young people can still get infected and can still spread the virus it's something important. It's a self-sacrifice for the broader community to try to still practice the social distancing measures.
Anyone else want to speak to the volunteering question?
Yeah, I would say that probably the very first principle in any volunteer engagement that you may involve yourself in is to ensure that there is a social distancing aspects. In terms of needs, I think we're going to have many individuals who are at home that may not have the typical social supports. We want to support them to stay at home, as I said, whether they are under medical recommendations to stay at home because of COVID, or we are recommending globally for people to stay at home. I think creative ways to be in touch with individuals who are at home, whether that's telephonic or video capabilities, would be excellent opportunities for volunteering for a younger, healthy population.
Thanks.
But I put a pitch in for tutoring. Our children are out of school, and you're talking about kindergarten through 12th grade. And tutoring can be very easily done for families who have a computer and internet access, or even a smartphone and internet access. And you can even do tutoring, believe it or not, by telephone. So there's a huge need, and the Yale School of Public Health is working with the United Way, and there is a new website that the United Way has opened up, which is going to permit people to make those kinds of contributions back to the community and still maintain social distancing.
Thanks, Sten. The next question also comes from somebody at Yale, Victoria Ellison. She says, why aren't international domestic flight bans being instituted and enforced? Should airports enforce this by shutting down? Does anybody want to take this? Sten?
This is a complex issue. Let's just first point out that flights have been cut radically. On some routes, they've been cut from 40 a day to 1. And there's almost no route domestically or globally that has not been substantially affected. You're going to see the airlines making more and more cancellations and adjustments. We're hearing stories of people flying planes with 150 passengers and 3 seats are being occupied, 147 vacancies. So there is almost a natural, with the social isolation recommendations, people's concern about exposure in closed spaces. People are walking with their feet and they're not traveling. So how could I defend somebody who actually does have to travel? Some of them are trying to get home. Some of them have to leave where they are. For example, our diplomats internationally are coming home in very large numbers. The entire Peace Corps is being brought home. So there is a global shift in where people are going. I think that routine business travel, holiday travel, things that can be deferred should be deferred. And I think you'll see that there is considerable social distancing, even on airplanes and even in airports at the present time.
Okay, thanks, Sten. Next question is from Prasant Imani. She says, my name is Prasant, and I'm an associate research scientist at Yale. My question is the following. What are the protective measures in place for New Haven's significant population of homeless people? What are Yale and New Haven contributing towards the provision of services for vulnerable populations? Who wants, Dr. Dalal, you want to take that first?
Yeah, I can start and then others can weigh in. So one of the strategies that we have in place that we're close to implementing in terms of logistics is a decompression of the homeless shelters. Our homeless shelters were not equipped to do the 6 feet social distancing, and they were also working at or near capacity. So we realized very quickly that we needed to decompress the shelters in order to maintain the social distance recommendation within the shelters. So we are about to bring online hotel rooms that will actually house up to 50 individuals that are not or not known to be COVID positive into hotel rooms and then for the protection of that population in that sense. We are also working to stand up a separate isolation facility for homeless individuals that do happen to test COVID positive, but that do not meet the acuity standards for hospitalization. We have multiple outreach efforts that I alluded to earlier, which includes ensuring that homeless service providers know the protocols with respect to screening individuals and are implementing them to the best of their ability.
Anyone else know Yale's role in any of this? Sten?
There's been activity in our Yale faculty working for the VA. The VA's done, David Rosenthal and colleagues have done a marvelous job housing veterans. But sometimes there can be housing insecurity, and they've been very aggressive in following up each and every veteran, many of whom are struggling with chronic medical conditions, including substance use or mental health conditions or chronic diabetes and the like. The Divinity School is actually getting involved. Ms. Cunningham on the faculty there used to be the executive director of Columbus House, and she's gotten extremely involved with the pragmatics of homeless housing and mitigation. I think Dr. Sinha may want to comment. We do have a challenge in our city in that nexus of homelessness, poverty, substance use, mental health, which is an independent challenge whether we have coronavirus or not. But I do feel like the Yale community stepping up to the plate. I just saw guidelines from our addiction medicine group guiding us exactly how we would like to tackle folks who are struggling with addiction issues, but maybe in harm's way with coronavirus, and strategies to mitigate that harm.
Thanks, Sten. This is a question from Michael Lawler, who's a Yale College grad from 1970. He says, given that the symptoms for all but the elderly, which I am, and or infirm seem to be trending towards mild to moderate symptoms with high recovery rates, and past viral epidemics, swine flu, H1N1 have infected and killed more people than COVID, please explain why these global actions are a rational response to the situation and not the greatest case of mass hysteria in recent history. I think there are a lot of people who think this is all overblown. Anybody want to weigh in here?
I tried to address that in my opening comments. I really feel like we should not underestimate the risk of a new influenza-like disease with 10 to 20 times the mortality rates being introduced to the human race and it taking hold and being with us forever. That is catastrophic. This virus is far better adapted to human spread than either of the prior coronaviruses, either SARS or MERS. And because we now know that it's just as good at spreading human to human as flu, it is worth this effort to try to see if we can run into the summer with extremely low levels of ongoing transmission and see if the summer dynamics will essentially scrub it out of the human populations the way that we saw SARS in 2004. So that's why I think it's not mass hysteria, and I don't think it's an overreaction.
Anyone else? Ellen?
Oh, there we go. So yeah, I would agree. I think this is an appropriate reaction in that. Also, if you look at what happened in China, in the epicenter of the epidemic where everyone got sick all at once, the mortality rate was much higher than in other parts of China. And you might wonder why that is. It has to do with the fact that a significant number of people do get quite ill with this. And it's not only people over 70. Just FYI, there are younger people who have gotten quite ill, have been in the ICU, and even died. And one of the factors, it's not just a property of the virus, it's a property of the healthcare system and its ability to cope with the number of sick people. If you have that number of sick people who need that intensive care that matches or is less than the number of ventilators and the number of doctors available, the mortality rate is going to be much lower and people are going to do much better. So it's not necessarily just intrinsic to the virus what the mortality rate is. It's how fast the virus spreads and how long the healthcare system has to build up to deal with this. So in the epicenter of this epidemic in China, that happened so fast, it was overwhelmed. Whereas in other places, the social distancing measures that are being proposed, the point is to slow that down, to stay below the threshold of what the healthcare system can handle. And that's going to make a huge difference in the outcomes that people have and the mortality rate of the virus.
Thanks, Ellen.
I just add to those, both of those statements by Sten and Ellen. Although MERS and SARS were not long ago, just the exponential growth in our travel is really, I think, year by year going to increase the risk of spread to every remote corner of the world. And I think we can also view this really in a larger global context. I think as Ellen was saying, I was on the call earlier with collaborators in an African country where I work. They have 5 ventilators in the capital city, period. So I think we have a larger global responsibility to limit this epidemic, because places that don't have the resources that we do are are going to be really potentially devastated by the spread of this virus. So I think there's another aspect to this. And as Ellen said, the experience in China shows that areas where there was not a lot of great infrastructure, mortality again was really high, and that was, as good an example of that impact that we've seen so far. Africa is hopefully not going to reach the point where Europe and the rest of the world has reached, but we just don't know that at this point. I think we need to take this incredibly seriously.
Thanks. So we have a few more minutes and a few more questions I think we can go through. I have a question from a Grace Parisi in Brooklyn, New York. She says, my son's college has suspended classes and asking everyone to leave. If there's a shelter-in-place policy for New York City, will I be able to pick my son up at the airport? The question, I think, can broadly be abstracted to think about, how do you understand all these public health regulations that are coming down that are telling us we can't do this and we can't do that? What are our obligations, and what are our can we get in trouble for doing certain things like picking up our children at the airport or things like that? Anybody want to jump in? Amy, then Paul.
Well, in general, if you look at some of the strongest measures that have been taken, like the measures in San Francisco, where there is a shelter-in-place order in place, they have exceptions for essential and necessary activity. And so there are exceptions for necessary work, necessary travel with respect to healthcare. And broadly speaking, I think what people who are writing those orders are trying to accomplish is communicating the message that everybody needs to socially distance and take this seriously, but not, to prevent people from doing things that are really necessary to be able to take care of their families. And so, you'd have to look at any specific order that came out to see how it would impact any particular place or activity. But my expectation would be that these are going to be written with the intent and enforced with the intent to allow people to take care of their families and take care of what's necessary to do. And they do have flexibility built into them for essential activities. And so, I think that hopefully that will be the case with ones going forward as well.
Thank you. Paul, do you want to weigh in?
Yeah, just to say that the principle of doing the things that you have to do is to do them as safely as possible and with the social distancing measures in place that are practical to take. So, for example, picking up your son at the airport, it makes more sense to do that in a way that you can get him home without the crowd of a public transportation if it were possible. If it's not possible, then you have to do that. We need to do the essential things that we need to do, but minimize the number of times that we have unnecessary exposures or non-essential activities outside the home.
So a little bit of time for maybe one or two questions. This is from Kyle Trentina, who's in the Yale Systems Biology Institute. I know several postdocs and grad students who intend on doing non-essential research throughout the shutdown, and I'm concerned. There's a notice from the president of the university about non-essential research, and a bunch of different postdocs and grad students are worried about having to go into the lab either by encouragement by their PI or on their own sort of willingness to do that. What is going on in terms of research that's non-essential at the university right now? Anne, and then Ellen, and then Sten.
Sten may know more than I do about this, but I guess as a researcher, the head of a research lab, actually these policies are evolving very fast. It seems like every half day we have a new guideline, but I think that the way that things are going is to shut down non-essential research. There are certain things, to maintain the infrastructure, such as crucial things for research like stored very important samples and things like that, which we'll try to maintain through this hiatus to not destroy those resources. But I think every day we're seeing more and more of from the administration of the idea that non-essential research which is research that's not directly related to trying to curb this epidemic, is being curtailed. Of course, as a research institution, one of our reasons for being is to be able to apply our knowledge to try to help in situations like this. So in that case, we don't want to shut those efforts down.
Ellen got it exactly right. I'll just add one thing, and that is animals. The animals have to be taken care of. The insectary has to be maintained. So that's an essential function.
Okay.
I would just add, in addition, I think there are folks involved in clinical trials at the university that are being followed, that are also in experimental therapies. That is not being shut down. So just want to reassure the public that, those are considered essential, of course. Those distinctions are being made.
So I think we have time for one more question. It's from Risa Sodi, who's an Assistant Dean of Academic Affairs in the Yale College Dean's Office. She's asking about, is it safe to play tennis or pickleball, which I don't even know what this is, outdoors in light of the guidelines for social distancing? I think the question is, what kind of exercise can people get safely during a pandemic? Sten?
There are sports that are contact sports that are very close quarters. The extremes would be things like football and rugby, but also soccer, volleyball. These are not advisable. This is a great opportunity for you to breathe on each other, to cough on each other, to spit on each other, accidentally, of course. And that's why the NBA has suspended its season. Now, the tennis players have also suspended their season, but it's not so much because one tennis player is going to infect the other. It's because there are large crowds that go to tennis matches and watch these matches and mingle and socialize. So in theory, the further apart you are with exercise, for example, I'm still going running and I'm giving a wide brief to anyone that I happen to pass on my run. And that would be still social distancing. So one has to use, I think, common sense. The specifics of tennis and pickleball, that the reality is you might go and chat with your partner and be close to that partner. That would be the risk, not being at the other end of the tennis courts. So I think one has to really think this through and be very cautious.
Okay.
I think these are...
Anne, go ahead.
I think it's worth noting that that to make a healthy lifestyle, with exercise, good diet, being able to sleep well, and taking care of your mental health and reducing the stress level will all help with building immunity. And so that's really important to reduce the risk of getting the infection.
Thank you.
And I think it's a really important point. I do very much worry about public's ability to, for the elderly, for many folks, it's really the way that they get out is getting to the gym or getting outside. And it's folks should still have your kids playing in the backyard. It's, maybe not in large groups or not with the neighbors necessarily, but some of this network theory that Dr. Vermund, Dean Vermund talked about, we might have to do more collective thinking about how to make this happen. There's also challenges in the inner city where folks don't have a backyard necessarily. I think we have to put our heads together and think about ways that we can let individuals get out there and get some exercise. It'll relieve mental anxiety and I think being in front of the TV like we are for a lot of the time is not healthy. So maybe for the person who asked about what you can do as a youngster is maybe help us brainstorm about ways that we can have people get out a little bit more, yet still maintain the social distancing.
Thanks, Neil. I want to thank all our panelists for being with us this evening from their various homes and apartments across the city. Stay safe, stay healthy, and we may have another one of these down the line, but hopefully you learned a lot tonight from our wonderful panelists. Thank you very much. Good night, everybody.